Welcome, everybody, to another episode of the Strength and Knowledge Podcast. I have a very special guest today, Dr. Makher. And Mike, you can correct me if I got that right, but hopefully I did. And he is coming to us from Portland, Oregon. He is a PT at Good Health PT and Wellness. And he has a particularly interesting story that I want to start with his trajectory into the profession. A lot of people have very, very good experiences with physical rehab, whether or not it's PT or chiro or one of those particular professions. But he actually had a negative experience, and this was while working as a business professional after graduating from Penn State. So, Mike, you want to just dive in and just kind of share a little bit about your trajectory into the field?
Oh, yeah. Actually, I'll clarify. So my negative experience actually started when I was a kid. So I had I have something called thumb hypoplasia. So my thumb basically didn't develop the way the thumb on my right hand didn't develop the way ideally one's thumb should. So I'm missing the FPL muscle in my thumb. So I literally cannot bend the IP joint in my right thumb. I had I was kind of hypermobile there in my thumb. And I had a surgery with like a legendary surgeon in the Philadelphia area. And then I went to rehab. They gave us a script, find somewhere for hand therapy. And my mom did what people who don't know anything about rehab does. She looked for the closest place that took her insurance. So she found a guy who worked in the back of a gym who didn't know how to treat hands and he didn't know how to treat kids. And I don't even remember his name, but he just gave me your stereotypical black and white sheet of exercises and putty. And I did what kids do. I damaged a putty. And then he was like, no putty, no more rehab because insurance isn't going to cover it, replacing the putty. And that was that. So coming from that experience, I always wondered what could have been done differently. But originally I was intimidated by PT because in Pennsylvania, we've got a lot of PT schools in the Philadelphia area. Pitt is one of the premier PT schools in the country. You got Delaware, one of the premier PT schools in the country just outside the state. You just hear people have to be nearly perfect. So I didn't go into PT. I went into business because I was interested in business. I worked in business and I realized working in a cubicle was not for me. And while doing that, I went and I volunteered at a workers' comp clinic and I actually saw some amazing things there. You know, a lot of people think of workers' comp. They think, oh, this is the worst possible setting. Some people will have very negative perceptions. They'll claim people are there to fake because they're suing people or something like that. But I saw a guy who was running on the treadmill a year after getting run over by a truck. So seeing that, I'm like, whoa, this guy can do that after getting run over by a truck. I'm interested. I saw a vestibular PT from an Emory trained specialist. And I was like, whoa, you guys can do this stuff. My only experience with PT was I don't know what he was doing. I was always wondering, how could that have been done better? And then I realized, wow, there are actually opportunities in this field. And I just kept volunteering and shadowing different settings. And then I got into the College of Staten Island. And from there, everything progressed.
Yeah, and it's progressed to the point where, you are not in workers' comp, right? You are focusing mostly on an environment that deals with chronic pain, individuals with EDS and other hypermobility deficits. At what point did that come on your radar? And what has that experience been like, just, really just being in a niche area of our profession?
Yeah. So chronic pain has been a kind of interest of mine for a while now. My stepdad he's had chronic low back pain for years now, and he had a laminectomy, a discectomy, and then a fusion, and his pain has not improved overall, according to his report, from all those surgeries. And seeing him struggle, going from being somebody who is very active, running a lot, walking a lot, to, to the point where like he's in bed half the time. If he just goes, he pushes himself a little too hard, which he has a tendency to do. He's one of those go-getters. He's going to end up in bed every time. And so seeing that, I was interested. So actually, as a student, my last 2 clinicals were with 2 people who specialize in chronic pain, 2 clinics, one being under Dr. Jonathan Fass, who now specializes in complex regional pain syndrome, most specifically, and then under Dr. Sandy Hilton at Entropy Physiotherapy and Wellness in Chicago, kind of learning more about the pelvic region and pain from that perspective too.
And those are both places where language is so, so important. I know that you mentioned a little bit of challenges surrounding certainty and uncertainty, and really, like a lot of us are realizing, getting comfortable with levels of uncertainty. But when language is really, really important, and when you're trying to put off a level of confidence to the people that you're working with, how do you manage some of the uncertainty and certainty that is going on with regards to patient care?
So it's a tricky thing. So I kind of like, one of the most important things I do is I listen to people and I try to see what their information is telling me about them. So are they somebody who's looking for certainty? Are they looking for somebody who's just going to make absolute statements? Or are they going to be open? And I tend to highlight the uncertainty with patients in my clinic, which is harder to do in your regular ortho clinic, because patients come in and, a lot of patients want a diagnosis, they want a label, they want to know what's wrong with me. And then if you tell them, well, it could be this, it could be that, it could be this, if you just say it that way, they're going to be like, okay, forget about this guy. I'm going to go to the other place.
That guy doesn't know what he's talking about, right?
Exactly. Whereas the patients who I see a lot of times, the overwhelming majority have had negative healthcare experiences. Some, not just some, most of them have had traumatic healthcare experiences. A lot of people have conveyed a lot of certainty about how they're hysterical, or it's all in their head, or they're making it up, or I don't know, I have no clue, go see your primary care provider, those kind of things. Or they've gotten like a false, misleading diagnosis. So when you're honest with them, they usually tend to like it. They're like, wow, I appreciate that you're willing to talk about like what you're confident about, what you're not confident about, and and acknowledging what I'm going through, because that's the biggest thing. The patient wants to feel validated and acknowledged, and that comes in different forms, and it's tricky, but it's very, very important.
Yeah, I love that. I think right where you started, first, just allowing them to be heard, right? Validating some of the concerns that they're having, recognizing that the experiences that they bring to the table are largely going to help you guide where things go when it comes to that plan of care. I think a lot of people in this situation, and I know you used kind of the phrase, like in a previous conversation, like clinical zebras, right? So these people almost feel to a certain extent that they're either like very unique, or that they have something that can't be categorized. How do you help people put the pieces together? Is this something where you are focusing on mechanisms? Are you just focusing on things that maybe would fall under a category where they're not meeting certain standards? What guides you throughout your time working with them?
Well, so like, since I work with like a lot of people, if they haven't been diagnosed yet with a specific condition like Ehlers-Danlos syndrome, I'm going to listen to them, and they're going to the big thing is it starts with the subjective. They start describing things to me like, oh, I keep dislocating my shoulder, or my kneecap keeps popping out, or my ribs keep popping out, or something like that. And I know for a lot of people, they hear that and they might be like skeptical, because like they're thinking from the perspective like, well, does that really happen that often, or something like that. And that a lot of people will say that online because they assume generalities. But we have to acknowledge that what the person is going through, whether real or just perceived, is still part of their reality. It doesn't matter if it's physically popped out, like visibly, or they're feeling that. We have to acknowledge it, and then we have to assess partially to validate them. So I look at them and I'll go through a quick screen, the Biden, just to see if they show some signs of hypermobility, for example. If they do, I'm like, okay, let's go deeper down this road to assess further. And then if I see enough signs, like, for example, there's a lot of comorbidities like postural orthostatic tachycardia syndrome, also known as POTS, where when they get up from sitting or lying down, they're extremely lightheaded, they have brain fog, they're disoriented. Sometimes they can't even articulate what they're saying. So that's one thing. If they have severe allergic responses to things, which could be associated with something called mast cell activation syndrome, that would be a sign. So all of these things we're piecing together and looking at, what are they telling me? Because that's the most important starting point. Our special tests, as we all know, are not, well, as most of us, I'm sure, are aware, are not so special. But we have to consider what the person is experiencing in our assessment. That kind of guides me in a direction of, well, this is what they're feeling. Let's take a look.
And with that information, I mean, are there any particular clinical pearls that you think are very valuable for maybe people that haven't experienced working with people with EDS or hypermobility as much? I mean, in terms of home program or modifications to physical activity routine, or maybe things that they're tracking. And real quick, before you touch on that, for anybody that's unaware, the Baton, right? Baton Hypermobility Index is a 0 to 9. And if maybe you can touch on that before you dive into clinical pearls. Yeah.
So the Biden, it's not a perfect. Okay, don't worry about the pronunciation, but it's not a perfect. It's not a perfect scale. It's just a preliminary screen. So with any screen, we don't have great screens in musculoskeletal care that I can think of off the top of my head. It's just a screen. It doesn't diagnose or not diagnose a patient, but if somebody has like 5 or more of those, you might want to explore hypermobility as a possibility. If it's less than 5, you got to think very critically, would this really be reasonable to look at this person this way? Maybe so, but possibly not. And that criteria, that scale is for hypermobile EDS. There's various forms of EDS. Patients with EDS tend to be hypermobile in general, but that's like a specific type. Having said that, it's a good first step to start looking at somebody. In terms of clinical pearls, it really depends on, again, you got to go back to subjective. If they keep telling you they're constantly getting hurt, that's actually, by the way, something I was thinking about before speaking to you. I was like, because I know you're working in a very sports-oriented clinic. Well, if you have an athlete, a female athlete, for example, because most people with EDS are female, and they're constantly getting hurt, and it's non-contact injuries, you might want to consider, are they hypermobile? And if they are, maybe they potentially are on the spectrum of hypermobility, where we got to look at this. And then, so considering what they've experienced in the past, what are their past experiences with exercise, maybe you need to pace them. Maybe you need to restrict them. Maybe you just need to work on body awareness. Like, how do I contract my abs? How do I contract my glutes? How do I contract my parascapular muscles? a lot of these patients, they don't have the awareness to do this without like a lot of like just co-contraction everywhere. So working on just, being able to learn how to use their body is very important. But the tricky thing is just everybody's different. So some people, you can jump right into things. Like I had a patient the other day, like visit 2, we were working on loaded deadlifts with the barbell. We were working on cleans. They look like they have some form of EDS. Other people, they're on the table. We're doing very tiny little body awareness things. It really just depends.
Yeah, the population I think that we will see that has a little bit more of the, displaying hypermobility characteristics is going to be our gymnasts, it's our tumblers, our dancers, our cheer type of athlete. And I find myself using an analogy with them when stuff pops up, that they have a higher seesaw. So they have access to a higher seesaw than some people. And sometimes their tension is because their body is working so hard to control this higher seesaw. And that the reason why they're tight is not actually that they need to take the seesaw higher, but we actually need to focus on just awareness of where we are in terms of that moving seesaw, how well we can control it. A lot of these athletes that will come in probably are doing more physical activity that's on the elastic end of the spectrum when it comes to muscle contraction. So we're diving into things like isos, eccentric, longer time under tension activities. Definitely don't see them quite to the level in which you see them. And I will say that oftentimes we probably get people who are hopefully, right? But unfortunately, they are sometimes earlier on that kind of chronic pain scale, so to speak, right? You have people that unfortunately are running into a pattern at an earlier age. We're not seeing people that maybe have been dealing with this for say 10 to 20 years, but it's definitely something that I think is interesting in that you're seeing a lot of EDS. And I also know that you're very passionate about strength and conditioning as a whole. Sometimes I find that this population base is told to do things that are maybe very, very low level with regards to physical activity. How do you handle some of those conversations, and how do you introduce things that look a little bit more like traditional strength and conditioning to this patient population?
Well, that's a good question. So one of the things I try to consider is, I'm always thinking like, all right, what is the point of what we're doing and how are we going to progress this? So working on that interoception, that body awareness, and kinesthesia, that the movement awareness and proprioception. So like, for example, if I'm thinking of the deadlift, one of the best exercises I can think of before the deadlift is the bridge. So working on the bridge and working on a stiff bridge. So with the posterior pelvic tilt and the abdominal bracing and the glute squeeze and getting them aware of all those components. I know that all sounds very like motor control-ish, but it really does help. And then we start off, we work on just the pattern. And once they get more comfortable with the pattern, I'll either take a kettlebell on and put it on like some kind of elevated step or box, or I'll get the training bar. And the training bar has made a huge difference in terms of this, just having that there. And then I put on 2 10-pound bumpers, and then I go through a lot of stuff that's very similar to what starting strength does. And we just talk about like all of the steps, we work through it. Every rep is an opportunity to reassess, reevaluate, and we just take our time. And for a lot of them, they really have a great experience with it, which it's fascinating just because that's not always the solution of pain. I want to highlight that, but for this population, it is often helpful.
No, I think that's great, especially with regards to some of the research that's out there on outcomes in this patient population base. So putting them in a situation where they can have these lifelong and sustainable physical activity, movements, routines, workouts, whatever it might be. I hear you kind of skirt around motor control, and I'm gonna draw kind of like this gross parallel, but I always think of like references like an encyclopedia, and we need to rep things out and kind of stack complexity with regards to anything academically. And I don't think that movement is tremendously different with regards to things like sequencing and progressing to higher level activities. So I don't think it's a far reach to at least say that we are building a foundation of lower to higher level complexity exercises. So I know that the motor control crowd out there might be like, all right, well, motor control doesn't help with pain, but it might put us in a better situation to have reference points to stack a higher level activity on top of. With strength and conditioning, you're also passionate about seeing it more often in the field, whether or not it's through mentorship, through continuing education in the field, or the formal education side of the house. What thoughts do you have in terms of recommendations? What would you like to see done?
Yeah, so I can tell you from my experience, I don't know what your experience was like in school, but the most I had in terms of strength and conditioning was we were very lucky. We had an alum who came in who was a competitive Olympic weightlifter and former trainer and strength coach at Rutgers. And she talked about like all of these basic exercise physiology concepts. And then she covered some of the patterns in a brief guest lecture series that she was allowed to do. But our TheraX class was taught by a home health therapist and a neuro rehab therapist. Neither of them lift. They don't know these things. So we weren't like, it wasn't a heavy emphasis. And a lot of people walked away with like, we don't really know TheraX. So I had to learn everything independently or post-graduating. And I think that like there's a huge gap in terms of opportunity there for improvement in terms of strength and conditioning for a lot of programs from the feedback I'm getting. A lot of people will say either nobody teaches TheraX well or the majority of programs don't teach TheraX well. And, I can't comment on each program. I've heard a lot of complaints, but I do think that we need that more. We need to start covering this, at least on a basic level, how to scale this, how to progress things, how to regress things, and to include these patterns like the hinge, the squat, including multiple versions of the squat, the bench press, the overhead press, push-pull patterns beyond just TheraBands or something like that, because we can do so much more. And this has been a huge criticism of ours, like from the lifting community. They've criticized us because it looks like we're just using rubber bands, and some people are because they don't know this stuff, but we could do so much better. And I've seen more and more groups pop up that are embracing this. Barbell Medicine is a great group. They've kind of emerged and they're talking about the barbell stuff. I know there's the barbell physio, there's a kettlebell physio, there's a bunch of people. There's also the people from the training side, like Starting Strength, which Barbell Medicine is kind of an offshoot, or Strong First, Dragon Door Russian Kettlebell certification. But if people go into those things and they look at them skeptically, they don't just accept everything they say, they just learn what they can from it, it can be very useful in their career.
Yeah, I mean, I think that makes me think of two separate topics. One, just the fact that we are seeing physical activity promotion more and more in our field, and recognizing that we can be an entry point to having some of these conversations with people, and hopefully be a catalyst for lifelong physical activity habits. And then I think you mentioned a little bit, just a challenge in terms of the fitness and wellness people, right? The people working in that industry, seeing this significant disconnect in terms of traditional PT, this gap, right? Nobody really addressing this gap. We've heard bridge the gap, all right, probably enough times at this point to recognize that we're not really preparing people for the fitness and wellness world as much. We need to do things to speak their language. We need to do things to prepare people to be successful in that world. Something that you just brought up that we've started to incorporate more. And we actually created a whiteboard that is erasable, but it has the foundational movements in CrossFit, Orange Theory, all of the other gyms around our area. But you've got your push, pull, overhead, hinge, squat, rotate, gait, so these different categories so that then people can walk out and they can go, all right, these are my modifications. They can go to their CrossFit coach and ideally be in a situation where the CrossFit coach is speaking the same language as the practitioner. And then that person recognizes that, okay, not only is it important that I have physician and rehab on the same page, but now I have rehab and my lifelong fitness coach, trainer, or whatever on the same page. So I'm with you. I mean, I think it's something that ideally, as people talk about PT not being used enough or people having negative experiences with rehab, I think the more that we learn about that fitness and wellness world, the easier it is for us to integrate there. And then as you talk about things like direct access, then people are coming to the middle instead of going all the way to the physician and having to come to us as well. So I think it serves a lot of different benefits. But when we talk about some of these various groups, they're doing a tremendous job of educating. They're providing mentorship. I know you're big on just developing good professional and personal habits. Do you have any recommendations for some of the newer grads out here or even people that are in PT school that you think would be beneficial at this point in their career?
Well, the first thing I would tell people who are just graduating and they feel like they really want advice is to remember that they are capable. They are already capable because they graduate from PT school. They learned some stuff. They now just need to spend the time and do the research themselves. Unfortunately, life is not easy. Nothing is, in most cases, rarely do we have things handed to us on a silver platter. You've got to do the legwork. You can go do a residency. You can take courses, but ultimately it's on you to do the work. You are capable. That is the most important thing I think people need to realize. They are capable of getting better. That uncertainty, as we talked about before, is always going to be there. If it's not there, that person who's absolutely confident in whatever they're doing is wrong. So you got to embrace the uncertainty. You've got to just embrace the process and focus on the process more than the end goals, because I know that's very generic advice, but it's really true. That process is going to be the part that you're going to be living in for the majority rather than the results. And as soon as you get a result, you're going to want a new thing to work on. So focus on the process, embrace that you're capable, embrace the learning. And most importantly, embrace that it's not about what we do. I don't care if it's exercise, manual therapy, whatever. Embrace that your role as a DPT, at least this is my message to people. Embrace that you're an educator. That's where you have to come from. You're not going to fix people. You are going to educate them. It's on them to ultimately take the steps to do the things they need to. You can help them, but you can't force people to buy into things. You can only present the information. So don't beat yourself up. Don't blame them. Just do what you can.
I love that advice, Mike. I think that's critical. I hear a lot of things, whether or not it's growth mindset or control the controllables in the back of my head, kind of undertones for some of that stuff. To kind of go into a conclusion here, I know that you have some exciting things that you're working on. I know that you're also very, very involved in our field, or at least getting more involved. Is there anything you'd like to share about some projects you're working on before we kind of put a bow on this thing?
Yeah. Well, I want to raise awareness for the clinic, Good Health Physical Therapy and Wellness. If you're in the Oregon area, you have a patient who looks like EDS, send them our way. We'll take a look. Currently working on a proposal for CSM 2022, hopefully related to EDS. Hopefully it'll get accepted. Some viewpoint articles, also part of the OPTA Continuing Education Committee, and we're having our conference. So please, if you're in Oregon, register. That's about it. Thank you.
Perfect. No, it's awesome, Mike. And I know there's people that are going to want to follow up with you after we're done here. Do you mind sharing real quick your, Instagram, Twitter, and an email as well, where people can reach out to you?
So the Twitter is probably the best way via social media. So that's at Mike, and then it's spelled, my last name is spelled M as in Michael, A as in Apple, K as in Kilo, H as in Harry, E as in Erica, R as in Roger. So that's Makher, Mike, at Mike Makher. You can reach me there. You can email me, Michael at goodhealthphysicaltherapy.com. Those are the two ways. I kind of keep my Instagram more private. That's it.
Perfect. Mike, really appreciate your time today. I think you're going to have a lot of people reaching out and definitely asking some questions. You're in a unique niche in the field, and you seem to be headed in the right direction and doing a lot of the right things. So thanks for your time today again. And I look forward to staying connected with you.
Thank you. And same to you.